So I think my talk has been made easier by the previous speaker who's speaking on OCT, because OCT A without OCT is again something which should not be done. It has to be after you have done your OCT that you go to OCT A. So whether it is beautiful or not beautiful, you decide after you have seen this presentation. So what is OCTA and how does it help you over OCT? We've seen that OCT already gives you a lot of answers. So it is high resolution, and as the name suggests, we are talking of angiography now. The only angiography which we knew earlier was fluorescein angiography, and this is also an angiography, but how is it different? How does it help you more than a fluorescein angiogram? It is high resolution. It means it shows you much more detail than a fluorescein angiogram would do. It is depth resolved. Now, fluorescein angiogram takes care of only one surface on top, which is the superficial one. It does not show you that there is a deeper layer and there is a vascularization under that layer also. It does not show you any of that. It does not show you how the choroid is opaque, how the choroid capillaries is opaque. So all those things are seen separately in OCT angio. And once the dye starts leaking, it obviates all other details. So which is why we used to have a definition called classic and a minimally classic, because the classic membrane would not leak so much or would be very clearly visible. Occult, because it was occult on fluorescein angiography. Now it is no more occult. The occult term is gone because OCT angiography is showing you all. So it is not occult. So there is no problem with dye leakage, and it is non-invasive. No more question of anaphylactic reaction, keeping hydrocortisone, keeping anesthetic standby, asking for allergy, keeping able, keeping patient will have vomiting, throw up, fasting, so many things here you can do. You can do multiple times. I don't like this one, go and take another one. You couldn't have done that with a fluorescein angiogram. You can't repeat a fluorescein angiogram like that. So this is the difference between a dye-based angiography and the OCT angiography. Dye-based angiography is invasive, OCT angiography is non-invasive, no systemic side effects, less time consuming. It's only two-dimensional, it gives you only a single surface on top. Now it is three-dimensional, it is depth resolved. I will show you the meaning of that as we go. And probably the only disadvantage at this point of time is fluorescein angiography is giving you the peripheral wide field view, which OCT as yet, OCT angiography, though already it is available, it is in the market, but a lot of us still don't have it, and soon I'm sure all of us will have that also. Basics is that how does it work? What is OCT A and how does it differ from OCT? Now OCT, you take those scans, say multiple scans go through that particular thing and you take the image. OCT angiography takes hundreds of scans to the one particular image, and then after little phase takes the images again in the same area. Now if suppose we are looking at phobia, in 1 second 100 scans go through phobia. In the second, after 1 second again 100 scans go through phobia. Do you think that there will be any change? No, because it will remain the same. The only thing which is changing in the retina, if there are blood vessels, is that the blood is flowing, the erythrocytes are moving. So this is so sensitive that if after a first scan and the scan done after 1 second, it perceives that change and that change it interprets as blood vessels, right? And it feels that only change is happening because of the flow of erythrocytes. So OCT angiography is so sensitive that it is picking up the flow of erythrocytes. Now it has a threshold. If the flow is very slow, it will not pick it up. If it doesn't pick it up, it will. No. If it does not pick it up, it will show there is no blood there or there are no blood vessels. So it will be a white. I'm just explaining it in nutshell what it is. So if it is very slow, even though blood flow is present, it will not pick it up. If it is very fast and it is beyond its threshold, it will again maybe not pick it up. So it is a particular threshold between which, and it works on the principle that if scans are taken at repeated regular short intervals, then the only change which is there is the change in the movement of erythrocytes and the blood flow, and the OCT angiography picks up. That is the nutshell of OCT angio. Otherwise, it is like OCT only. So repeated B scans are required from the same retinal location, and the differences is nothing but decorrelations between successive scans are calculated, and these calculated differences are interpreted as presence of flow of blood or flow of erythrocytes. So this is the TS is the time it takes for the scanning of a particular area, and it scans like this, and then it again scans like this. Correct? So scanning like this is TS. This movement is TF, T-fly, because it has to go back, right? To scan again the same place. So the total acquisition time is TS plus TF. So interscan, how much ever longer the period is, it will be more sensitive because it can pick up even the slower flow. But if there's a longer interscan time, you will have more blinks and motion artifacts and everything coming. Because remember, the principle is only thing which is supposed to move is the erythrocytes and blood cells and blood flow. Eye is not supposed to move, eye break is not supposed to be there, patient is not supposed to move, chair is not supposed to move. If any of those things move, your OCT angiogram will get affected. So that is the principle, which is what has to be remembered. And then it takes those images and puts it in form of NFAS images, because now the reflected light which scans which come back is taken from the nerve fiber layer, from the inner nuclear layer, from the inner plexiform layer. So different layers it takes back and then gives you images through different layers. Because it is giving you blood flow through different layers, here it becomes depth resolved. Because it is showing you what is the image going to be like in the nerve fiber layer, blood that flow is going to be in the nerve fiber layer, what is going to be in the inner nuclear layer. So these are the 4 fluxes it recognizes. This is the superficial capillary fluxes, intermediate capillary fluxes, deep capillary fluxes, and radial pericapillary capillary fluxes. As the name suggests, radial pericapillary capillary fluxes is actually only a very localized area which is there around the nerve. So that is not something which you have to, most of it now studies are coming that glaucoma can be studied with these low blood supply. Most of the machines at present combine the intermediate and deep fluxes and show it as a deep fluxes. So for betterment of us, for us to understand, there are 2 fluxes that you need to remember, which is superficial and deep from the retina point of view. And this is how it looks like. This on the left hand side is the radial capillary fluxes. This is the superficial fluxes. Superficial fluxes, you will see these large vessels, and this is intermediate and this is deep. If you note carefully, already a normal eye, FAZ is much smaller in superficial and FAZ is much larger in the deep fluxes. Little bit on vascular anatomy. If you know me, you will have to bear with me because I go to the basics when I ever have a talk. So when we know the blood supply of the retina, central retinal artery gives rise to these vessels, the arteries that we have, and this then breaks up into arteries, arterioles and capillaries. This is largely your superficial venous fluxes. All of us are very used to it because fluorescein angiography has always shown us only the superficial venous fluxes. So superficial venous fluxes is actually similar to the fluorescein angiogram. Okay? And superficial venous fluxes actually supplies the deep fluxes as well as the radial fluxes. If the vessels from it go deeper to go into the deep fluxes and superficial to go to the nerve fiber layer and the radial fluxes. So on the left hand side here is your superficial fluxes, and on the right hand side is the deep fluxes. Now, as I said, the major vessels are all on the superficial nerve fiber layer, they go down. So the image, the fluxes that a picture that you will have on the deep fluxes is going to be fine capillaries. That is what you see. And the large capillaries that you see down is nothing but the projection artifact. That you see, it's the same vessel which is going in the superficial fluxes is sometimes seen down also. This is an artifact that superficial fluxes which should not have been seen in the deep layer is also being seen. So it's actually an artifact. Once you start seeing it, you will know that that large vessel does not belong to deep fluxes. Deep fluxes looks only like fine small capillaries. Okay? This is because of the segmentation lines. Now the segmentation lines, any machine will tell you what exactly inner boundary is from 3 micron from the internal limiting membrane. I am very bad at numbers, I don't remember it. But you must all know it, you must all remember it. When I interpret, I just remember superficial plexus is just below the nerve fiber line. Deep plexus is on the intermediate is actually on the inner side of the inner nuclear layer, and deep is on the outer edge of the inner nuclear layer. So this is grossly, you have to know, Gauri told you where is the inner nuclear layer. Once you see that in the OCT, a mental picture, and I'll show you here. This is the thing I remember, that you have your superficial plexus superiorly close to the nerve fiber layer, or maybe I can use this. And you have your, you can take the slides for me. So you have your superficial plexus here, and you have your intermediate plexus here, and your deep plexus here. So this is how it goes, and this is, following this you have the slab formation, right? So this is the slab that you have, various slabs. First we show that it is the vitreous, which is the vitreoretinal interface. This is how it looks like. So you can see here again, once you see this, you will realize if you're sick, this is called the segmentation line. This is where it shows from where is the this portion of retina is being imaged. So this is the vitreoretinal interface. Here you should not have blood vessels. So this is black. So this is now the superficial layer just below the nerve fiber layer. So this is the superficial layer. Then comes your deep plexus, and this is your deep plexus, which is along the inner. I think I'm close to the.
And we can use the pointer in this.
I'm using it, but I think it's not very visible.
Okay.
It's visible now on the screen. Okay, it's very small.
Change the color.
Okay, so now this is how the choroid layer comes. So this is, as Dr. Gauri told us, we have the choriocapillaries. You saw the choriocapillaries were just below the RPE, and which is just below the RPE, the choriocapillaries is fine capillaries. As we go to the Sattler's layer, it's the larger choroidal capillaries, and then we go to the Haller's layer, which is even larger. And the reason you can see larger vessels here is, again, as we go towards larger vessels, the blood supply in the larger vessels goes on becoming slower and slower, and which is why they are appearing blacker and blacker. It's not that the blood is not there, it's because the blood flow is very slow in the larger choroidal vessels, so they are appearing black. Now, why do we have to do this? So though my basic talk is not over, but I'm taking you to the applied so that you don't go off to sleep here. So we do some quantitative analysis also, and most of the machines will give you a quantitative analysis, which is vessel density. There is a particular definition of it. I'm not going to into detail. As the name would suggest, how densely packed the vessels are in that particular area. So as the patients are diabetic, more and more we are seeing, there are so many of diabetic patients who have not yet developed diabetic retinopathy. A lot of research has been done, and OCT angiograms have been done, and they have seen that even if they don't have an obvious diabetic retinopathy, vessel density is already reduced. So the importance of this is so huge. If you start seeing these, it's a non-invasive method. You start seeing, machine is giving you the calculated vessel density. You put the patient on a better control, you may actually never develop diabetic retinopathy. Right? There are studies which have shown, in fact, I myself have done this study, which have shown that if your HbA1c becomes okay in a pre-diabetic, the vessel density becomes normal. So you have a parameter which can tell you, and we can reach a stage. In fact, decrease, and this decrease in vessel density happens before the enlargement of foveal avascular, which is what we traditionally used to see at foveal. So this is the example which shows you that all layers, whether it is a superficial layer or it is a deep plexus, all are affected, and this is something called the composite. So this is also, you need not be afraid, you don't have to make it. Every machine gives you a composite which is there, it shows all the plexus together, and the color will be different for blue, purple and red depending on whether it is superficial vessel or deep or thin. So you can see the superficial also, here the black areas are going on increasing, the deep, the black areas are going on increasing, here deep also increasing, and as the severity of disease is increasing. So this is something which you can see on your own machine as you follow up these patients over a period of time. You do this and keep in every year, and every year if you see that these are going on increasing, the actually patient is having pathology. You can see mild PDR, moderate PDR, severe NPDR, and PDR, how the differences are there. First thing, which of the first layer is getting affected? It is the deep capillary plexus. So even before the superficial gets affected, the deep one is going to get affected. And lower the vessel density in the deep capillary plexus, more they are at a risk of developing PDR, even in eyes where diabetic retinopathy is present. So look at this. This is one of my cases only. You can see how superficial capillary plexus still looks okay, but look at the deep capillary plexus, almost gone. And this patient still has to have developed diabetic retinopathy. Again, though the superficial capillary plexus looks normal, the deep capillary plexus already the vessels are so less. This is foveal avascular is another one that enlargement can be seen. And with DME, if you associate this kind of a picture, this is what they call drill. See, OCT is showing you drill, that there is no, the lamination between various layers is not well seen. And the cause is underlying ischemia. You see how the blood vessels are already gone, and that is why there is ischemia. And this kind of DME, how many ever anti-VEGF you give, even if the fovea becomes flat, patient will not visually improve. You would have seen so many of these in your practice as well. So to summarize, FAZ is significantly larger in DR group and more so in DME group, and it is a useful biomarker. A little bit on why DCP is more affected early, because DCP, if you know the anatomy, you know that the inner area of the retina is supplied by the central retina artery, outer is supplied by the choriocapillaries. DCP is coming somewhere in the watershed zone. So the ischemia, hypoxia is first going to shut down the smaller capillaries, which is what DCP is all composed of, which is why it is such a useful biomarker. And as I said, why is it important? It has got prognostic value. You can see here disorganization of DCP and response to DME is also less. Other biomarkers, you know, microorganisms, if they are present in superficial layer, they are a problem. But if you see these images in the deep layer, then it is even more of a poor prognostic marker. Enlarged FAZ in DCP is a poor prognostic marker. This is another very useful thing. Now, with the presence of OCT angio, you are able to see these fine vessels without doing the angiogram itself. On a fluorescent angiogram, we knew that if it is leaking, it is a neovascularization. If it is not leaking, it's an edema. Now here we don't have a diagnosis. So how do we know? If you see this new vessel tuft and you see a corresponding OCT here. So this is, if you can see from the back, this is a new vessel tuft. But if you see the corresponding OCT scan, there is nothing which is crossing the nerve fiber layer. If it is not crossing the nerve fiber layer, it is an edema. As the name would suggest, it is still intraretinal. Here, it is crossing the nerve fiber layer. So this is a new vascularization. It is beginning to grow into the vitreous. This is your branched retinal vein occlusion. You don't need an angiogram to see whether which area is getting occluded and what is the extent. Yes, if you need to see peripheral neovascularization, you will still have to do an FFA. But if you get hold of the wide field OCT, then you may not need it. Scan size. Scan size is also very important. Just as I told you, what scan you want to do, a cube or radial, raster, which one? Scan size is also important. This is again, same thing, superior, same scan at 3 millimeter and inferiorly at 6 millimeter. And this is a 55-year-old gentleman who just came with an accident. He decreased vision. Left side is a 6 millimeters. And for neovascularization, AMD, you should definitely do a 3 millimeter scan. For my protocol is that for DME patients, I do a 6 millimeter because I want to know as much of what is happening around. For my AMD, I do a 3 millimeter. Though if you do both, it is good, but sometimes in a busy OPD, this is a protocol you must tell them that this is not to be missed. In an AMD, 3 millimeter is not to be missed, and in DME, 6 millimeter is not to be missed. But still, I think 6 millimeter gives a lot of value because it gives you the fluid amount, it gives you the loss of choriocapillaries. So as I said, I like to see more scans. Again, an example, if you wanted to see what PCV looks like, you can see again This is not OCT angio. This is OCT. This one here. And you have this thumb-like elevation with double layer sign. This already should tell you that you're looking at PCV. This is a 3 millimeter scan. This is a 6 millimeter scan. And you can see this network. But probably this polyp is not very clear. But if you see a 3 millimeter scan, you can't miss that polyp. Why have I put this? This is your that very benign and very simple and humble looking structural infrareflected scan that you give any OCT. That itself is showing you a polyp. You don't need ICG for that, right? In fact, I'll show you in my next talk also that this is one of the criteria for diagnosing of PCV, that the structural scan, infrared reflectance scan, which is present in every OCT, it shows polyps so well that you can use it to measure the area and treat the patients. Again, you can see neovascularization of PDR very well. And here, if you combine it with OCT, you get it all. This is a patient of PDR, which has got DME, which has got IRC, which has got neurosensory detachment on the right, and on the left, it has got hyperreflective foci, it has got edema and no neurosensory detachment, and it's PDR. So, everything, whatever you want to know, you know it in a scan, you don't need anything else. So, is Octa an answer to all problems? So, let us see. Arm to retina time. When it's not a frank CRVO, it's not a frank VRVO, you want to see the flow is sluggish. No, you can't do that on OCT angio. Because OCT angio only tells you blood flow is there, not there. It does not show you it is coming slowly, or it's coming late, or it's not filling. So where these occlusions are concerned and you want to see that the flow is sluggish, you have to do an angiogram. And then field of view, as I mentioned, till now, we don't have too many machines which have a wide field. So if you want to see this kind of neovascularization, you still need to do an angiogram. If you have FEVR and diseases like that, which are all happening, action is happening 160 degree in a way, you still need an angiogram. Coats disease, where you want to know where the leakage is happening, you want to pick up areas of leakage. You need leakage, and OCT angiogram does not show you leakage. MA, when you want to do focal laser, you still need an angiogram. CACR, it won't tell you. It does, but you really need to look for it. But it has to be done on an angiogram, multifocal CACR. Myopic CNV. Why myopic CNV, you would ask? Because here, due to presence of staphylomas, due to presence of very thin choroid, due to presence of, you can see that on a myopic patient, hardly there is any choroid and sclera is right there. So because of that, there are so many artifacts that if you have to sometimes pick, whether it's a CNV and small CNV and developing, you may actually have to do a fluorescein angiogram. Asteroid holosis. Then asteroid holosis, you cannot see the retina at all. Fluorescein angiogram is the best investigation. You can see, you don't even know that you are in the case of asteroid holosis. But if you do OCT angiogram here, you see how many artifacts you get, and you see fluorescein angiogram shows you so much. So what are the other artifacts? We did speak of artifacts in OCT. Look at this. The moment you have even a floater, large floater, or a large vitreous hemorrhage, look at this, what is happening to your OCT angiogram. It is no good. But if you do a fluorescein angiogram, you will get the information. So this is, you have to be careful, because here it is not an artifact really, because it is a loss of signal. These are motion artifacts. Best seen on this, again, that humble photograph which comes next to the OCT. Look at that. You will see these motion artifacts. Movement of the eye is always seen like this. Now the OCT-A has an inherent mechanism. See, because as I said, if you can't have the patient so still, it usually takes about 5 to 10 minutes to take angiogram, and you can't have the patient so still. And not only movements, so the blink movements are there. They say that even the choroidal pulsations are present. During the diurnal change, there is some amount of choroidal inherent movement also. Then there will be some microsaccadic movements which can happen. So it has an inherent mechanism. The day OCT-A became commercial, it became commercial with this. So it registers whether it is from the same place the scan is being taken. If the patient is moved a little bit, it will move. It will move back to where you wanted it to focus. Suppose I have taken a scan today, and next day again after 1 month I want to take the scan and see what is happening to the memory. How will we go on finding that memory? Automatically, the machine will register. From the memory, it will go back. You ask it to register, it will go back to the place where the previous scan was taken and take the scan from the same place, same site, which is makes it. So eye tracking and registration is available in the software. Projection artifacts, we did speak when you see those large vessels from superficial plexus onto the deep plexus because the segmentation lines are not correct. You can see here, as I mentioned, on the left hand side, those are with the arrows, those are the projection artifacts. The superficial vessels should not have been seen, but they are being seen. There is a software again in the machine. It can show you the deep plexus without the projection artifacts, or which is called the PAR. Automatically, it removes your projection artifacts. Segmentation lines. Now again, as I said, in myopia, because the distortion is so much due to stereotypy and all that, here you can see your segmentation line should have gone through the choriocapillaries. Because it is so thin, it is going out of the eye. The automatic segmentation which the machine gives you is out of the eye because the choriocapillaries choroid is so thin. So because it is out of the eye, look at what is happening there. It is showing no flow. But that is because it is incorrect. So you have to see where your segmentation lines are going. This is another example. This is more common. All of us will quickly just look at this and say, I don't see a CNM. You don't see a CNM because look at this. This is your ORCC slab. Where segmentation lines should be in the choriocapillaries and just above into the outer retina. Where is it? RP is gone up because of pigment epithelial detachment. Auto segmentation is gone below. So until unless you go to the machine and correct this, you will not see anything. Which is why you don't see any complex. Here probably it's to some extent correct, so that some complex. So large PETs, large area of hemorrhages, all these places, OCT angiogram will not show you the. Again, because of presence of large cyst, this can again give you some pseudo artifacts and some pseudo reflection in the center, suggesting of flow, but there is no true flow. When you don't know that your segmentation lines are correct or not, you see this top corner, you can see, I showed you this top corner, this one. This image. This is a combination of superior, deep, and gives you this together. So you will be able to pick up anything which is there in any of these layers without trying to separate which layer it is. So OCTA is no longer a research tool, and we can even quantitatively and qualitatively see these patients, but the problem is we have to learn again, new nomenclature, new things, and I will continue the session, which will be more clinical in my next talk. Any questions from now? You can ask.
And in cases of CSR,
Yeah.
in cases of CSR, OCT angio should be preferred only in the recurrent cases or the first episode only you should do this as an investigation?
In CSR, actually, I would not recommend any investigation in the first stage. Generally, that is the teaching. That you need not do, just limiting and all those things. But these days, for follow-up, whether it is decreasing or not decreasing when the patient comes next time, and the more you know, more problem it is. I will think, am I missing something else? Is there a PCV? Is the patient is more than 50-year-old, so that it could be something else? If it's a typical history that 25, 30-year-old is having this kind of thing, you can still think. And maybe if we go into the next topic that shows how OCTA has changed the treatment of CSR altogether, we'll get more answers from that.
So in diabetics, which layer becomes more important? Either the superficial plexus or the...
So the deep plexus gets affected first. That is definitely there. But all your NVEs and all those things you are going to see more in the superficial plexus, you won't see. And when you prognosticate, because I said ischemia, that deep plexus comes in the watershed between the blood supply to inner retina and outer retina, so that gets affected first. So most of the changes in deep plexus will happen between no DR to mild to moderate NPDR. After that area has crossed, then most of the changes start happening in the superficial. So if the patient is coming in advanced stages, then superficial layer will give you more, because deep plexus would have been obliterated by then.
So when do you prefer OCT and pass Octa if there is doubtful area, doubtful NB or asymmetric DR cases?
So you can do a montage which is non-invasive, and you without see sometimes you are just, and I combine it with the fundus photograph also. See what you see clinically on an indirect. Major advantage of fundus photography is you can magnify it and see any irma, any small red dot which appear on indirect. You increase in size and see whether it is an NVE or anything. So those doubtful cases I am able to get away with fundus photograph. Montage is not that easy to get. And even with the Cirrus 6000 that I have, max is 12 by 12. It doesn't go beyond it. You have to have the sweat source OCT to go beyond it, or the newer OCTs which can take you even further. So a combination of montage, if I'm really suspicious, with the fundus photograph. I don't mind doing a fluorescein angiogram also if I'm really thinking that it could be. Sometimes you see sclerosed vessels, or you see posteriorly, if you do, you see some capillary non-perfusion areas. If you do an OCT angio, then you definitely take up the patient for a fluorescein angiogram.
What is the role of angiography
So optic nerve head, as I mentioned, there are radial plexus which is there peripherally. In fact, now the newer studies are that there is thinning of this plexus in patients with primary open-angle glaucoma, and that is, they believe that it is the ischemia which is causing the thinning of your lamina fibrosa, and which is why it is kind of becoming deep cups and all those things. So there are studies where they are studying this area in and around radial pericapillary network in glaucoma also. So here we don't know where the ischemic optic nerve, it's not because of the radial plexus that AION is happening, right? The blood supply of optic nerve will be totally different. This is blood supply of the retina that we are seeing in OCT angio. You will have to use anterior segment OCT. So I'm not sure if even anterior segment gives you vessels of the conjunctiva. That you will have to use probably photography of the anterior segment and all. But Cirrus 6000 comes with anterior segment OCT module as well, which is what we have. So most of the things in cornea angle you can see in front of the iris. The dictum is whatever is in front of the iris is very well seen on anterior segment OCT. Whatever is behind the iris is seen on UVA. That is usually the dictum.
Another question. So ma'am, since the DCP is effective first in pre-diabetics as well as diabetics who have not yet developed DR and DR, so do we offer OCT angio routinely to these patients? And how is OCT angio? How will OCT angio fare as a screening tool in such patients?
See, in that area, I would say we are still in the area of research tool, because you have to think ethically also. You can't have every patient paying you that amount for your investigation. No, that is also not acceptable. And finally, if you see that the DCP is going, you're going to ask the patient to keep your diabetes under control. That you can do even other diabetics, anyway it's good. So there, that part, it is helping us understand the disease pathology, right? Doesn't mean that everything has to be converted into a daily clinical. I would say that you definitely should be judicious when you are using investigation, and it should not, what I have shown today should be reflected upon and you think about to understand it, not to just do it for every patient, and that should not be correct. Use it judiciously. Okay.